Welcome to today's lecture on scope and rationale of endodontic treatment. The learning outcomes for the lecture are: describe the scope of endodontics, which includes the indications and contraindications, explain the rationale of endodontic therapy, describe fish zones of periapical reaction. Let's look at the indications of endodontic treatment. Endodontic treatment is usually performed when dental caries involves pulp. The various clinical conditions listed under this are irreversible pulpitis, pulp necrosis, apical periodontitis, acute and chronic periapical abscess, and dentoalveolar abscess. Sometimes, if in non-carious lesions like attrition, abrasion, erosion, or even abfraction, if it extends more from enamel, dentine, and towards the pulp, causing pulp exposure, we may have to do an endodontic treatment. Tooth may also become non-vital due to iatrogenic causes, that is, causes caused by dental treatments. Firstly, if there is a pulp necrosis due to tooth preparation for crown, or any deep restorations causing pulp exposure, or acid insult from etchant while doing a composite restoration, or cements or unpolymerized resins may also cause pulp necrosis requiring a endodontic treatment. Sometimes tooth may become non-vital due to trauma, or else tooth may become non-vital due to orthodontic treatment. This happens if the force exerted during the orthodontic treatment is excessive, or if the movement of the tooth for orthodontic treatment is carried out very fast, then the tooth can become non-vital. The most common tooth becoming non-vital due to orthodontic treatment are maxillary and mandibular anterior tooth. Other indications for endodontic treatment are crown fracture involving pulp, root fractures except for the cervical third of the root, or endoperio lesions, and pre-prosthetic where intentional root canal treatment. Pre-prosthetic, when I say where intentional root canal treatment is required, when you are doing a tooth preparation for crown, if you believe that it may lead to pulp exposure, okay, you may have to do root canal treatment first and then followed by the tooth preparation, so that after giving the bridge, the tooth may not become non-vital. Okay. Now, coming to contraindications to endodontic treatment. First, let's look at the local contraindication. The first is vertical crown root fracture involving most of the root length. Here, when you do a root canal treatment, it is usually not successful, and the treatment here is extraction. So when you do a root canal treatment, what you aim at is to establish a complete seal between the root canal content and the periapical tissues. But if there is a root fracture like this, you may not be able to achieve that seal, and there is a constant ingress of microorganisms and its toxins from the periapical tissue into the root canal, which is already been filled, leading to failure. So in most cases, if there is a vertical root fracture, the choice of treatment is extraction but not root canal treatment. Periodontally compromised tooth, okay, as I said, endoperio lesions or periodontally compromised tooth, you may have to do a root canal treatment. But in certain cases, if the tooth is periodontally compromised, that is severely periodontally compromised, as you see here, a picture, a radiograph is there of a premolar. In the premolar, if you see the bone loss is extending almost till the apical 1/3, so it is severely periodontally compromised. So here the endodontic treatment, even though it has been done, the treatment may not be successful. So in these cases, when the tooth is severely compromised and there is severe bone loss which is extending up to the apical one third. The better treatment would be extraction followed by replacement of the tooth. Okay. If the bone loss extends only to the coronal third or middle one third, still you may consider endodontic treatment followed by periodontal treatment. But if the bone loss extends till the apical one third and the tooth is exhibiting marked mobility, then the endodontic treatment may not be successful. So better consider for extraction. The other local contraindications, they are not absolute contraindications, but certain times the anatomy of the tooth or conditions within the root canal may not enable you to completely clean the root canal treatment. Okay, if you cannot achieve complete asepsis of the root canal followed by three-dimensional filling, the root canal treatment may fail. Certain conditions like severely curved or dilacerated root, where you will not be able to clean the root and followed by filling, tortuous canals, or instrument which has been broken within the root and it is not possible to retrieve it. So in those cases, if you feel that you will not be able to do a perfect root canal treatment, then the first option is to refer it to a specialist. But if you consider that even by referring this tooth for root canal treatment to a specialist, the treatment will not be done, then the choice of treatment would be extraction but not root canal treatment. If you see one more contraindication is caries involving the floor of the pulp chamber and furcation. In these cases, to a certain extent, you may be able to do endodontic treatment. That would be to open access, locate the perforation site. Either you can locate seal this perforation site by using agents like mineral trioxide aggregate or biodentine and seal it off. Okay, then followed by root canal filling. But in certain cases, if it is a long standing caries involving the pulp and floor of the pulp chamber and in the furcation area, and you feel that this perforation cannot be sealed properly or the bone loss is very severe at the furcation area, then you may have to go for an extraction instead of an endodontic treatment. There are certain perforations which cannot be sealed. In those cases, the choice of treatment would be extraction. Among all the root fractures, the poorest prognosis is for the root fracture occurring at the cervical third. Now, you may ask me that why the root fracture occurring at the cervical third has a poorest prognosis. The reason is that there might be a constant source of ingress of bacteria and toxins from the oral cavity into these perforation site, leading to failure of the root canal treatment. So compared to middle third and apical third root fractures, the fracture occurring at the cervical third is usually having the poorest prognosis and endodontic treatment is contraindicated. Extensive root caries occurring subgingivally is also a contraindication for root canal treatment. Coming to systemic contraindications for endodontic treatment or root canal treatment, there are no specific contraindications for RCT. In medically compromised patients, it's rather preferred to do a root canal treatment instead of extraction. But before you initiate a root canal treatment or any dental procedure, it is always better to obtain consent from a physician that the patient is fit for root canal treatment. In most cases, you may have to prescribe prophylactic antibiotics, 2 grams penicillin 1 hour before treatment and 1 gram after 6 hours. You may also have to discontinue certain medications temporarily if required. These things can be done only after the consent from the physician. An astute clinician must be able to differentiate pulpal and periradicular problems from other pathological entities, in which cases the pain may mimic the pain caused by pulp and periapical diseases. These conditions are trigeminal neuralgia, cluster headaches, temporal arteritis, atypical facial pain, acute maxillary sinusitis, cardiogenic jaw pain, herpes zoster, TMJ dysfunction, and any pain resulting from malignant neoplasms that may mimic pulpal pain. To explain the rationale of endodontic treatment, Fish, a scientist, proposed a theory which states that if you are able to remove the nidus of infection, it would lead to resolution of pulpal and periapical infection. This became the basis for successful endodontic therapy. Now let's look at what endodontic therapy can do. If you do a root canal treatment, you remove the vital or necrotic pulp. So this is called removing the nidus of infection. After removing the vital and necrotic pulp, it is replaced by an inert filling material, which may result in complete repair of the periapical tissues. A root canal treated tooth can function normally provided the periodontium is healthy. When bacteria or microbes gain access to the sterile pulp, they cause infection by invasion, multiplication, and then exerting their pathogenic activity related to the host response. The various routes of microbial ingress to the pulp are through an open cavity or through dentinal tubules and through gingival sulcus or periodontal ligament or through the bloodstream, broken faulty restorations, or through extension of a periapical infection from adjacent infected tooth. So after the bacteria enters the pulp tissue, it can lead to tissue changes which can be degenerative changes like necrosis and suppuration, or if the bacteria are less virulent or the irritants are very mild, it may act as stimulants. So in these situations, in the center of the inflammatory area, the irritants may be strong enough to produce destruction, but at the periphery, the irritants are very mild, leading to proliferative changes, leading to formation of granulation tissue. Let's look at experimental foci of infection. A scientist, namely Fish, he performed an experiment. In this experiment, what he has done is he has drilled some holes in the jaws of the guinea pigs, and into these holes or openings, he packed woolen fibers which are saturated with broth culture of microorganisms. So after he did that one, he sectioned these jaws and observed the various zones which are formed around the areas around the microorganisms, which are called as a fish zones. So if you compare this if you compare this with a normal tooth, and let's consider the dental caries involving pulp as the area where the fish has placed the microorganisms, and let's look at the areas. So whenever a microorganisms enter into the pulp tissue, okay, which is the first stage, then they start multiplying. So the microorganisms actually do not move. They are not very much motile. They do not move from the entry to the periapical area, but actually they multiply, and then they gain access to the periapical areas. So once they gain access to the periapical areas, you can see four zones, which are the zone of infection, zone of contamination, zone of irritation, and zone of stimulation. The area closest to the microorganisms is a zone of infection, and the area which is farthest from the microorganisms are present are called zone of stimulation. Coming to zone of infection, as I said, is the area where you find the maximum microorganisms. Here you find necrosis as well as marked infiltration of neutrophils. Area is characterized by presence of large amount of dead cells, protein decomposition products due to neutrophils, containing microorganisms, exotoxins, endotoxins, and enzymes. The next zone from zone is the zone of contamination. Here you may find lots of round cell infiltration characterized by cell destruction. This cell destruction is not caused by the microorganisms but from the toxins released by the microorganisms. The predominant cell in these areas are lymphocytes. The next zone would be zone of irritation. Here there is presence of macrophages and osteoclasts. Fish found evidence of irritation further from the central lesion as the toxins become slightly diluted here. Histological picture in this zone is of one of a activity preparatory to repair. And zone from the microorganisms are zone of stimulation. Here it's you find that the toxins are very mild. This zone is characterized by presence of fibroblasts and osteoblasts. The toxins are mild enough to act as a stimulation. In response to the stimulation, you can see a lot of preparatory activity for repair. So you can find collagen fibers are laid down by the fibroblasts here. This is how we can sum up the rationale of endodontic treatment. The root canal is a seat of infections. That is, the microorganisms in the root canal are not motile, but they do not move from root canal to the periradicular tissues. However, they can multiply sufficiently and grow out of the canal, or the toxic products of these tissue necrosis may diffuse into the periradicular. Um, as the microorganisms gain access, they are destroyed by the neutrophils. But if the microorganisms are virulent or more in number, they can overwhelm the defensive mechanism, leading to periradicular tissue. Microorganisms are usually transients in the periradicular tissue. The transient invaders are completely destroyed by the neutrophil leukocytes once the root canal treatment is completed. So in conclusion, root canal is the seat of infection. When the root canal is treated, the infected periapical region will undergo repair. Thank you very much for listening. We'll meet in our next lecture, which is on diagnosis of endodontics. Thank you.